Patient arrives in A&E with right hand dominant. Middle-aged woman with pain and swelling along with redness. She's worried that her fingers are spreading apart. She confirms that she stabbed herself with a pencil a week before, but does not remember any pain or bleeding at that time. You can see a puncture wound has converted into a small blister of calyx. She did not have any medical attention at that time and now comes up to the A&E. She does not have diabetes and has no allergies to any medications. Now we go on downstairs to see the patient. She had pain while removing her jacket. There is obvious swelling in the second web space, distal to the palmar crease. The swelling is more on the palmar aspect, but is visible on dorsal aspect as well. She has some abducted position of the finger at rest. She is able to flex and extend the fingers actively, but report pain. There is a fluctuation and tenderness on the web space, along with cellulitis changes. No signs of vascular compromise is noted. At first instance, you try to think of cannibal sign and you examine the cannibal signs to confirm flexor tenosynovitis, which is negative. In this case, multiple differentials can be inferred: pyoderma gangrenosum, gout, or volar web space infection. In this case, it was an interdigital web space infection resulting in a collar button abscess. A web space infection can happen because of infected calyx on the volar side. The abscess can spread on the dorsum aspect, resulting in a collar button abscess. Regarding the treatment, for superficial cellulitis, IV antibiotics can be used. If infection tenosynovitis is diagnosed within 24 to 48 hours, it may be treated with antibiotics, splintage, and hand elevation. But operative intervention is usually required. Infection can happen because of Pasteurella, Echinella, E. coli, Enterobacter, Pseudomonas, and Serratia. In Pasteurella and Echinella, ampicillin or penicillin is the antibiotic of choice. In E. coli, first or second generation cephalosporin can be advised. In the Enterobacter or Serratia or Pseudomonas, aminoglycosides can be added up with cephalosporins. The treatment of collar button abscess is prompt surgical drainage. When an hourglass abscess is present, it is required to have incision both volar and dorsal side. We have to make sure that no incision is done transversely across the web space, because scar formation can result in further fingers abduction. Several incision techniques have been advised for the palmar side. Incision is begun just proximal to the ulnar end of the proximal flexor crease of the radial digit of the two involved fingers, and continued proximally and ulnarwards, stopping just distal at the mid-palmar crease, overlying the metacarpal of the ulnar digit involved. After the skin is divided, subcutaneous tissue is spread with the clamps until polar material is encountered. The abscess is enlarged longitudinally. The surgeon applies pressure from the dorsum of space while the wound is retracted. A second incision can be made at the dorsum of the infected hand. This incision begins at the level of metacarpophalangeal joint. It lies between the metacarpals and extended distally in a straight line to end at the base of involved web space for about 1 to 1.5 centimeter. When the dorsal collection is entered, the opening is enlarged in the direction of the wound. After the infection has been evacuated, the wound irrigation is advised and drained with gauze wicks placed in both wounds. The hand is dressed with a compressive dressing along with a plaster splintage, which can be removed after 48 to 72 hours. A supervised hand therapy is advisable to encourage motion of the hand digits. An alternate approach is a palmar surface approach with a zigzag incision, starting just proximal to the web and stopping just distal to the mid-palmar crease. This type of Z sort of incisions, these flaps are reflected and the deep tissue dissected in the web space, while the digital arteries and nerves are dragged to either sides. To provide ample exposure of the volar and dorsal compartment of the dumbbell-shaped abscess, the superficial transverse metacarpal ligament and other fibers of the palmar fascia are divided. A generous communication between the two incisions is established, and the drain 16-gauge polyethylene catheter is inserted into the palmar wound and sutured in the skin to prevent accidental removal. The volar wound is sutured around the catheter. A small Penrose drain is placed into the dorsal wound. Manual irrigation with saline is done to certain that the irrigation solution exits dorsally. The hand is dressed in a compressive dressing and a plaster splintage, and a continuous irrigation system is devised with sterile saline at 100 ml per hour, maintaining it for 48 hours. The outflow spills and collects onto the dressing. When there is a spillage, an inspection is done and the wound is assessed. If found to be free of infection, the catheter can be later on removed. Exercises are started with the dry dressing.